Good evening and welcome to our NERVANA event. My name is Dr. Lisa Faherty. I'm Associate Professor of Nursing and Public Health at the Regis College School of Nursing, more specifically the Young School of Nursing, and I am delighted to be your MC for the evening. Just a quick review of our agenda. Thank you very much for your patience in the interim, but just a quick overview as to what the evening will bring you. So we have our introductory welcomes, sharing of the veteran patient story from Dr. Charnas, our Chief of Staff, the introduction of our wonderful guest speaker, Dr. Claire Burgess, by Judy Wendt, the Associate Chief of Nursing Service and Academic Affiliations for VA Boston Healthcare System. Of course, our guest speaker, who will be speaking on Serving All Who Served, Best Practices in Transgender Veteran Healthcare, our question and answer session, and then our concluding remarks and evaluation component. Again, welcome. Thank you so much for being here tonight. Just a quick overview as to what we hope this event will bring to you. The purpose is to provide a forum for clinical and academic partners, as well as guests, to share insights about the care of veterans, to generate ideas for advancing nursing and interdisciplinary practice, education and research for America's heroes, their families and caregivers, to define the term gender identity, to discuss the purpose of the standards of care from the Worldwide Professional Association for Transgender Health, to identify a best care practice in interacting with transgender and gender diverse patients. Please know that the event has been approved by the Massachusetts Rhode Island League for Nursing for 2 contact hours. The criteria for contact hours or course credit, if you're attending tonight in hopes of receiving credit for a specific course, do include attendance of the entire event, including the question and answer session and submission of a completed evaluation form. Please note that the evaluation form link will be made available during the question and answer session in the chat box. The scheduled speakers and related committee members have reported no real or potential conflicts of interest. This educational activity is free of bias and financial interest. This educational activity is being recorded. That is, it's being recorded by Regis College. All attendees are thus asked to and prohibited from separately recording the event or otherwise reproducing or disseminating the related materials. To optimize event attendance for all this evening, we do ask that you mute your microphone and turn off your video camera for the duration of tonight's presentation, unless, of course, you're a scheduled speaker. If you were unable to secure Dr. Burgess's presentation slides prior to tonight, please know that they are posted for free access and download at the link provided on the slide. And for the hyperlink is provided both in text and at the bottom of your slide. If you need a quick access to it, please know that this will bring you to the registration page for the evening. Please submit any questions to the Zoom chat box itself during Dr. Burgess's presentation. Dr. Cheryl Kelleher and Dr. Donna Berry, both of Regis College, the Young School of Nursing, will be monitoring the Zoom chat box this evening and share all the submitted questions during our scheduled question and answer session immediately following the presentation. So please feel free to actively engage in this evening's presentation. Ask questions as you think of them so that we can capture your thoughts and ideas during the scheduled question and answer session, which we of course hope you will stay for. The SurveyMonkey evaluation form link, which is required for contact hours of course credit if that's what you're seeking tonight, will be made available in the Zoom chat box during the scheduled question and answer session immediately following Dr. Burgess's presentation. We do ask that you submit your completed evaluation form. It is very brief, no later than tonight at 9:00 p.m. So please be aware that the evaluation form link will cease to be open after 9 p.m. tonight. So please do submit in time. Your contact hours certificate will be forwarded in the coming days to the email address that you provide on your completed evaluation form. So when you do open your evaluation form, that is the SurveyMonkey link, the very first question that you'll be asked is your preferred email address for receiving the certificate. So please make sure that you complete that question. And without further ado, I am pleased and privileged to welcome Dr. Donna Glynn, the Associate Dean of Pre-Licensure Nursing and Associate Professor of Regis College at the Richard and Sheila Young School of Nursing and a nurse scientist for the VA Boston healthcare system. Welcome, Dr. Glenn.
Thank you, Dr. Ferry, and thank you for your attention to detail. It's so appreciated. So welcome. Tonight is a phenomenal opportunity for the Regis College Young School of Nursing to participate in the Colloquia series on the care of the American veteran. Regis College has been a strong partner in the NERVANA team. NERVANA is the Northeast Regional VA Nursing Alliance, and Regis has been an active participant. I am thrilled to have tonight's topic, even though due to COVID, it took us 1 year to bring this to fruition, but it is an important topic, and a topic I'll share that when I began my nursing career was never discussed. So I think it is important that we begin the conversation for some and strengthen everyone's knowledge related to this important population within the VA healthcare system. The purpose of the Care of the Veteran series is not only to educate particularly nursing students and other students in the health sciences regarding who choose a career in the VA, but this forum provides an opportunity for us to educate all who will care for our veterans, because as we know, veterans receive care at all settings, not just within the VA walls. It has been my privilege for the last couple of years to be a nurse scientist for the VA and to work with the veteran population. So on behalf of Regis College, I want to thank as the VA, particularly Dr. Mcfay, Cecilia, and Judy Wendt for their hard work in putting this together. I would like to thank the Regis Faculty Development Committee for working with Judy and her team to have tonight be possible. In particular, I'd like to thank Dr. Burgess for sharing her expertise with us. So I'm looking forward to an informative evening. Thank you.
Thank you, Dr. Glenn. And now I'd like to welcome Cecilia Mcfay, the Associate Director of Nursing and Patient Care Services for the VA Boston Healthcare System.
Thank you so much. Can you all hear me?
Yes, thank you.
Yes, can you hear me?
We can, Cece. Go ahead.
Oh, great. Hi. Sorry about that, the delay in having NERVANA present again. NERVANA Colloquia series, Care of the American Veteran. We appreciate all your hard work over this last year with the pandemic, and we struggled on what to do, whether we should try and wait and do a face-to-face or go with the technology and do it this way. And so, not wanting to postpone anymore, we decided to go ahead tonight, and we're really glad that you're able to join us. Sorry for the delay. I just wanted to let you know a little bit about NERVANA. We've been together for over 10 years, and we have 6 of the most prestigious schools that affiliate with Boston VA and Veterans VA, they being Boston College, UMass Lowell, UMass Boston, Simmons, Northeastern, and Regis, which is where we are tonight. We used to try to do this twice a year, but again, the pandemic slowed us down a bit. But I think it's been a rewarding series. We're really glad that you're able to join us. And I want to welcome you all on behalf of NERVANA, and thank you all for joining us. And I will now turn it over. I'm not sure if Dr. Connor or Judy Wendt will be next, our chief of staff.
Thank you very much. And yes, I would like now to direct our attention to Dr. Charnas, the Chief of Staff at the VA Boston Healthcare System, who's kind enough to share a veteran patient story. Dr. Charnas?
Thank you so much. And I wanted to just share the concept of this story, and then Judy Wendt is going to read the story. We are always interested in knowing the whole person when we deliver care. And it is sometimes difficult in the midst of providing care to really get to know somebody. So there's been a project that was initiated at the Madison VA and has spread to at least 40 or 50 VAs across the country, but also now to Brigham and Women's Hospital and some of the other private sector hospitals, which is called My Life, My Story. And in VA Boston, we have trainees who sit down with a veteran, for an hour and let them tell their life story in their own words. It's transcribed, given back to the veteran to review, and then it's entered into the progress notes with a unique note title so that somebody who will be going into the room with this veteran will really have a three-dimensional understanding of who they are as a person beyond the information that we usually solicit when we ask for a social history. So I'm going to allow Judy to read this story, and you will appreciate when you hear the story how valuable this is in allowing somebody to know a patient and better deliver their care. Judy?
Thank you, Dr. Chanes. So the story in my life, my story begins with living there for the first 4 years of my life. My paternal grandma evicted us from the house we were living in. We moved to Norfolk County for a year and our house burned down. So we moved to the greater Boston area and I lived there until I was 17. I was raised in a poor single parent household along with 2 sisters and a brother. I tended not to have a lot of friends growing up. I wanted to play with dolls. I didn't want to go and do what the boys did. I hid who I was most of the time. I always got into fights. Plus, I was a kind of fairy at first. Then I became a very tough fairy, a fairy who had a good right hand. I was beat by my mom a lot too. I showed early signs of being feminine or wanting to be feminine, so she tried to beat that out of me. I was caught dressing when I was 12 years old. She sent me to a mental health clinic. I was lucky they weren't very good at their job. From that point on, I learned how to really hide. I started playing a lot of sports to show that I was a guy or could be a guy. Also, it was a great way to get out of the home. I ended up doing pretty well playing sports, which was a good venue for me. I still had a lot of those feelings. I tried to always doing daring things. I didn't want to say I was suicidal. I didn't want to outright commit suicide, but if someone dared me to do something, I would do it. I wanted to get through college through a sports scholarship, but I cut the tendons in my left hand on accident the summer before my scholarship for baseball was going to start. So they pulled that scholarship. Later, a friend and I were smoking a joint, and I said I wanted to get to see the world. And there was a billboard right behind him that said, join the Navy, see the world. So I went down there and 2 weeks later, I was in the Navy. I thought I could hide there, but the feeling was still there that I was trans. I would always volunteer for things that were hard or challenging or more manly. I did a lot of boxing. That's how I lost my sight in my left eye. When I was in the service, I was a cook. After I lost my vision in my eye, I kept having severe migraines, and they thought it was the heat. So I got out of the kitchen and did retail, ending up running a sunglass store for about 7 years. I eventually went to school of culinary arts, got my chef's degree, and got back into the cooking world. I was always a sous chef or a chef. I didn't want to go into management. I would just do my job. I didn't talk about my life or anything. I didn't want anyone to find out, so I kept it hidden. I got married toward the end of my service career. I had my son when I was still in the Navy. After I got medically retired, I had a daughter as well. I still had feelings about being trans. It led into a big spiral into drugs and alcohol. I ended up getting separated. I think that was when I tried to cut my wrists. About 6 or 7 years after that, I climbed an oak tree and tried to hang myself. That was the last time I tried to kill myself. That was 21 years ago. It was then that I realized I needed to get help for the feelings and the problems I was having. I didn't understand at that point that I had a gender dysphoria. The first therapist I went to told me that there was something wrong with me. Same with the second. So with my experience as a kid and the experiences with these two, I didn't think therapy was going to be the answer. I eventually got into a therapist who sat down with me and told me I wasn't alone. I learned about gender dysphoria, and my therapist could understand what I was going through. I remarried my wife after I cleaned up my act. I came out to her completely by mistake. We were having an intimate night and she asked which lingerie to wear. I told her the absolutely sexy one. She joked, I was always afraid I'd find you home wearing it. You'd make an ugly woman, I responded. No, I wouldn't. So we stayed up and talked about it. It was the first time I was honest since I was 3. We tried to deal with it. The fact that I was with her for so many years before I told her, she said she couldn't trust me anymore. So I ended up separating from my wife again. We never got divorced. When I finally came out, I told my judge, asked me why, and I said my social group and transgender. I ended up getting laid off despite having a perfect record. She actually got fired for doing that. About 10 years ago, I went to Dodexo after working about 6 months. I came out to my general manager and he said, okay, what can I do to help? Which actually shocked me. I started physically transitioning, taking hormones. I ended up becoming retail manager, then production manager. I did their Lgbt management guide, which has been seen worldwide. I started doing public speaking. Then I wanted to get into the Lgbt national group, but to do that, I had to have a higher position. About 3.5 years ago, I slowed down and started taking a picture a day. It's never just one. It's always 10 to 30. I realized I had to stop and see beauty despite all the poop I had on me from growing up. I'd had a lot of luck and have people to love. Physically, I abused my body. I on a daily basis. That's why I want to do something without feeling pain somewhere. Up the stairs to my apartment, I used to run the stairs every day. Both my kids have been pretty accepting. Once I had them, I didn't need anyone else. I want my tombstone to say, didn't let life kick them down, was always optimistic, or taught their children to love. I grew up with a lot of hate and bad parenting, so the most important thing to me was that we feel loved and supported. That's my legacy, always supporting others. That's the end. Dr. Chanas?
He dropped off a few minutes ago.
Oh, okay.
Thank you. Thank you, Judy and Dr. Charnas. And this is actually a beautiful segue because I would ask Judy now to introduce our guest speaker. Just for reference, Judy Wendt is the Associate Chief of Nursing Service and Academic Affiliations for the VA Boston Healthcare System. And we're pleased and privileged to have her here and to introduce our wonderful guest speaker, Dr. Claire Burgess. Judy, again, if you please.
Thank you very much, Dr. Fadi. So my introduction to Claire Burgess, who I've had the pleasure to work with for a number of years. Claire Burgess, PhD. She has, since August of 2018, Dr. Burgess has served as the role of clinical psychologist at the VA Boston Healthcare System, with specific responsibilities as a lesbian, gay, bisexual, and transgender veteran care coordinator at the Brockton campus. She also is in private practice as a clinical psychologist in Eastern Massachusetts, as well as instructor at Harvard Medical School. She's a graduate of College of Wooster in Wooster, Ohio, and received both her master's and PhD degrees in clinical psychology from the University of Southern California. She has published a dozen peer-reviewed articles on the subject of LGBTQ health and recently published a book on violence against LGBTQ persons. She considers herself a lifelong learner in how to improve patient care experiences and make care accessible for all. Today, she will present some of that topic, as well as her journey into the field of LGBT health at VA Boston. So without further ado, Claire Burgess, welcome you in your presentation.
Thank you very much, Judy, for that really warm and outstanding welcome. And it's really a pleasure to be here. A big thanks to Regis for putting on this talk, and Nirvana and Judy for your organization too of the talk and us being able to meet this evening. So as a part of me welcoming you here, I wanted to just say a little bit more. The title of our talk today And it's called Serving All Who Served. So we're going to focus on best practices in LGBT health with a specific focus on the T of that acronym. So thinking about transgender and gender diverse veteran care. All right. And
Thank
as a
you.
part,
I'm sorry, go ahead, please. I'm sorry.
oh, go ahead.
I would just stop sharing so that you can start sharing.
Let's see. Give me just 1 second. Okay, how does this look to folks?
You're-
This is good, okay.
You're good to go.
And so everyone should be able to see the first slide. All right, and so here we go. This should be an overview of me, my information, and the title of the talk. So again, my name is Claire Burgess, and I work at what's called the National Center for Telemental Health. So again, my focus is in clinical psychology, but I also have these additional roles kind of in teaching and education. And then this role that Judy had noted too, in being what's called an LGBT veteran care coordinator. And there's a few different hats in this role, hats of ethics, kind of care coordination and patient care, but also those of education. So I'll talk a little bit more about this role tonight and also kind of my journey into VA. All right. To get started, we have a very full talk for this evening. So the agenda is going to include what goes into the term gender identity. And to get there and to kind of unpacking that phrase, we're going to talk more broadly about LGBT health, distinguishing concepts of gender identity, sexual orientation, and also concepts of sex assigned at birth or birth sex. All right. What we're then going to do is we're going to take this knowledge and kind of use it to discuss some services that we would offer within VA, and then more broadly, kind of best care practices. All right. And also why those services, they matter in particular to transgender and gender diverse veterans, given what we know about health disparities and kind of a larger body of literature. All right. You'll be able to walk away from today's talk with some specific recommendations and resources in terms of patient care. Right, so in terms of concrete and specific objectives, by the end of our meeting tonight, you'll be able to define the term gender identity. You'll be able to explain the purpose behind standards of care from what's called WPATH, or the Worldwide Professional Association for Transgender Healthcare and Medicine. We'll be able to identify a best care practice, or maybe several, in interacting with transgender and gender diverse patients. All right. And so in talking about these kind of objectives, I wanted to note one thing as well, that I will speak more broadly about LGBTQ topics and patients. Within VA, we like to use acronyms. So the specific acronym that we use to designate LGBTQ plus patients or veterans is just the acronym LGBT. So if you find me saying that some today, it's not kind of at the exclusion of other people, but it's just because kind of the acronym that we use and is official within VA. All right. To start a little bit today and to kind of connect with where you're at, I wanted to go back in time a little bit to my graduate school days and talk about kind of how I came to VA and to training at VA. So this is a photo here from when I started, actually 10 years ago, just about from when I started my graduate work at the University of Southern California. And you can see me here wearing the tie-dye shirt there in the middle. And so in graduate school, I knew that training specifically within VA and at VA Boston would be a top-notch learning experience. It's kind of something that's talked about as this golden kind of star capstone experience after graduate school. And I kind of put aside thoughts of coming here to the East Coast, which is where I'm from, for after graduate school, because the West Coast was very pleasant and wanted to stay there. Looking back though at this photo and kind of reflecting on what the start of graduate school was like, I realized that all of the people in my cohort for clinical psychology, all of us trained at VAs, which is kind of a unique thing. So we trained at VA Boston, the Greater Los Angeles VA, the Palo Alto and the San Diego VA. So I think that that fact in and of itself just speaks to how valuable a learning environment and experience working at a VA can be. All right, after graduate school, I had moved to San Diego for a clinical internship, and I was working at a private hospital there. While I was there, I was involved on a committee that was dedicated to kind of how do we address people who are in acute distress or inpatient in terms of gender identity. How do we do room assignments, things like that. And so on this committee, we kind of set out to do some research, and we kind of went to the literature and looked at what was known on this important question and how to kind of best care for patients inpatient based on their gender identity. We kind of came up with two resources and two answers to the question. One was a resource from what's called Lambda Legal on how to do room assignments that had some guidance. And the other was actually from VA and was specifically some guidance that came from VA Boston. All right, so when I was applying for kind of the next leg of my journey and my training for my fellowship year at VA Boston, I knew that this meant that I would have resources and be surrounded by other clinicians, some of whom are on this call, who dedicate their lives to kind of understanding minority populations and what keeps individuals engaged in care and leads to quality care experiences for all those who have served our country. And so I highlight this point in my journey to VA because I think it can be a rare find in an organization to have both the time and the resources available to examine these sorts of questions. I know that I think maybe Donna was sharing when we were getting started today, that this is not something, a topic that's typically covered in graduate school, kind of regardless of era, and we're seeing it kind of increasingly covered. So I'll kind of start off today talking a little bit about that, all right? The more we know about patient engagement and kind of understand the nuance of trauma-informed care and patient experiences is going to really matter in improving patient wellness and reducing distress, particularly today around gender identity and gender distress. All right, so to kind of hit this home a little bit further, I wanted to look at the data and kind of ask the question of how many hours might we get in graduate school training kind of dedicated to LGBTQ health. All right, we know from medical schools, pharmacy schools, nursing schools, dental schools, different surveys and how many hours people report. One survey I came across said that the median number of hours, at least for physician education, is 0 hours on this topic. Other studies indicate that we might receive like 2 hours on this topic or as many as 5 hours, right? VA has always offered care with respect to diverse identities. So there's this nice juxtaposition and an offering that we have at the residency program, and as well as for students, if you come through to and meet with me for an hour talk that I give, I think it's more than an hour this year with Danielle Newman. We always kind of incorporate this as a part of our learning as a cornerstone. So I kind of, to represent this, I pasted below here in the slide some different literature about ways that we get at health disparities and we get at diverse veteran health, right? So here on the bottom, you'll see something from what's called the Be There campaign, which is a suicide prevention campaign, something from the Office of Veteran Health Equity. And then a neat thing that I kind of came across and co-created, kind of a non-discrimination statement and brochure of patient rights and responsibilities here locally. So the neat thing about coming to VA and a career in VA is that you have an opportunity to leave a mark in terms of the work that you do. All right. So this question asks, when affirmative care practices are taught in medical settings, we know that the effect's going to be overwhelmingly positive. Education about LGBTQ individuals is going to prepare us to care for these individuals and other patients as well, because it means that we gain experience in an area that's originally kind of uncomfortable for us and that we might not know the answer in, right? And so the act of going out and finding evidence-based information, consulting with our peers in a way that refines that evidence is going to be helpful kind of regardless of what the initial question is, right? So I wanted to look at this and say, what happens if we increase our exposure and our experience in this realm? What might we find or expect? So here we find that exposure leads to an increase in positive attitudes. So specifically, if we give someone an education and the appropriate terminology to use in meeting with the patient. And sexual wellness, sexual orientation terms, we find that this means that they're more likely to ask about things like sexual history, right? So the frequency and the comfort that the provider has in doing like a sexual history evaluation or assessment with the patient is going to increase. So this has a huge payoff in terms of preventative medicine and health for that patient. And it means that also screenings that we might do for cancers and other things will be appropriately collected at the appropriate increment or frequency. Right. And so just coming back for a moment and kind of noticing, if you want to think kind of in your mind, what are the spaces or the opportunities that I have, either in my day-to-day work or in education, to kind of interface with these questions and talk about them with my peers, right? It might be rare, and this talk, for instance, might be one of them, right? We'll come back to this question a little bit later. At this point in time, I wanted to make a shift. So before going forward, and actually for our purposes today, kind of talk about some of the terminology, all right? So the term LGBTQ. LGBTQ stands for lesbian, gay, bisexual, transgender. And you'll hear me use the term that's now used in the literature, gender diverse, as well. So within VA, another acronym we like to use is going to be TGD, or transgender and gender diverse. You'll find that these terms are kind of always changing, even within the empirical literature. They've changed from like gender minority to transgender and gender diverse. Other parts of the acronym you might see would be acute, which can stand for queer or questioning if we see it twice. And I'll talk more about that term. An I for intersex, another term that we'll define later. An A for asexual, and so on. So you might see a plus sign to denote that these terms are kind of always changing, and we want to be inclusive and all-encompassing. All right. To talk a little bit more about these terms in action, like what they mean for me, how I would define myself using them, I like to use this here. This is called the genderbread person. All right, sounds a lot like the gingerbread person. And so when we think about being LGBT and falling on a gender identity and a sexual orientation spectrum, I like to use this person because it kind of divvies it up and it says what's what. And I put my own spin on this. As you can see, I've drawn a line here, a blue line. So that way on the top portion on the right, we have concepts related to gender and sex. And then here in the bottom right, we have concepts related to sexual orientation. And I included sexual behavior. I would add that there as well. All right. And I want to talk more in depth about each of these. So to do so, I'm going to start with the upper right kind of category. And so this is a zoomed in version of the concepts related to gender and related to sex. All right. So here at the very bottom, you'll see a concept that they label biological sex. Another kind of newer term that we might use to discuss this would be sex assigned at birth, right? Because that actually captures what happens, right? So the physical sex characteristics that you're born with, and a doctor notices, okay, they're coming from the womb, here is kind of what I'm seeing. And this can include the genitals, shape. This will also include different aspects of chromosomes we might have. So other terms besides male and female we would use to kind of describe sex assigned at birth are going to be intersex as well. If we find that not all those chromosomes or characteristics that we see on the body align. Intersex is the term we'd use to describe the body. Up one from there, you see gender expression. So just like sex assigned at birth or biological sex, gender expression is something that we all have, all right? There's kind of two continuum here in terms of feminine and masculine. And this can be defined as the ways that you present gender. This could be through your actions, dress, demeanor, and how those presentations are interpreted based on gender norms. So all of these kind of come within a certain time and a certain place, right? A context, a cultural context. I like to use the example in thinking about this of kind of clothes we might wear to church, or what we might wear if we play tennis, for instance, how fashions might change, and they might mean something within a certain era and something different later on, right? So we all express our gender, but we might not think about what that expression looks like, or it might not be salient to us, whereas someone who's gender fluid or might notice changes in terms of the identity piece might then seek to change their expression as well and be more in touch with this. Some different terms that we might use to describe gender expression are listed here on the right. You can see androgynous, gender neutral, butch, femme, effeminate, things like that. You'll note too that there's these two different arrows here towards feminine and masculine that indicate a continuum. And then there's kind of a cross off to the left. This could also mean that if we're gender neutral, non-binary, maybe we don't ascribe to the system culturally that's in place. Maybe we're kind of off of that continuum. So there are various terms as well that speak to that. The last term, and maybe the most important one, is here at the top. And this is the term gender identity. This term speaks to how you in your head define your gender based on how much you align or don't align with what you understand the options to be for gender. And so we typically think about gender in terms of a binary, you're a woman, you're a man, like that. When our gender identity and biological sex align, we would say that someone is cisgender. And if they do not align, that's when we use the term transgender to describe a person. Right? And there's some additional terms listed here, including genderqueer, or again, kind of terms that don't believe that this that this has to be kind of a dichotomy between woman and man or one another. All right. We'll kind of come back and talk a little bit about the nuance here, but for now we will leave this topic and look at terms, basic terms around sexual orientation. This one I'll go through a little bit more quickly just because it's not as pertinent to our talk together today. But when we think about sexual orientation, it is separate, totally separate from terms around sex and gender identity. The two don't necessarily have to be related, right? We can think about sexual attraction in terms of physical attraction, also in terms of romantic attraction, who we're interested in dating, having relationships with. And lastly, I like to also think about sexual orientation as it relates to sexual behavior, because how a patient might describe themselves in terms of their sexual orientation may not line up with their sexual behavior. So it can always be good to ask about that if you're wanting to do a sexual wellness screening. All right. And so here we again have continuum of being sexually attracted to women versus men. And then on the left-hand side, you'll see the term nobody. So some people have the label asexual if they report kind of low or no attraction. And we'll come back to that label and talk a little bit about that as well. But this covers kind of the topic of sexual orientation. And so there it is, kind of taking together the genderbread person. Sometimes patients won't use terminology appropriately. So sometimes this can actually be a really helpful tool for kind of getting the conversation started, at least in terms of how to address oneself. These are my pronouns. I go by this name. It could be a nice tool too if someone's saying, well, boy, I really don't know how my gender expression fits in or how my gender identity fits in and how that might not be related to sexual orientation. Just to review, the terms I mentioned earlier, cisgender is when gender identity and birth sex do align. Transgender might be when they are different and they don't align. In terms of sexual orientation, the term pansexual, which you might have heard, technically means all loving. So it means that you might experience attraction that doesn't have respect to sex or gender identity. Bisexual means strictly attracted to both men and women. And then the reminder that sexual orientation and gender identity are not necessarily related. I had a patient once say, well, now that I've transitioned and I'm a woman, does that make me a lesbian? Because I still like women and want relationships with women. And I said to the patient, that's kind of up to you in terms of the terminology that you use and how do you describe yourself. All right. And so again, this can go back to a gender binary. Sometimes if we're working with an older adult patient, they might ascribe more to a binary, and someone who's younger might think differently about cultural concepts. and find that concepts of gender don't really have to be related to a binary female, male, woman, or man choice. All right, queer is a term that is used more often and was originally used to mean someone who does not identify as straight or cisgender, but could be an umbrella term meaning many different things. So a 2019 study using a Gallup poll found that people who self-identify as queer, they tend to be cisgender women or identify as genderqueer non-binary. So again, off of that spectrum in terms of gender identity. They also tend to be educated, according to this poll. Other terms that I said we come back to include asexual. So asexual people tend to be women and tend to identify as gender non-binary and tend to be young in terms of age. What's notable is that they're less likely to report having had sex in the past 5 years and less likely to report experiencing sexual attraction. This gets back to those bottom quadrants of the genderbread person and thinking about what constitutes their sexual orientation label. It's important to note here in terms of the romantic relationships themselves, there are no distinctions. Many studies show in terms of how frequently they're involved in intimate relationships compared to people who don't identify as asexual. So again, they're just as likely to be in a committed relationship as someone who doesn't identify as asexual. So if we kind of take a pause from the genderbread person and concepts of sexual orientation, I wanted to talk about some different theories people might have specifically about transgender and gender diverse patients. So to kind of do this, I wanted to propose a Mythbusters session here. All right. So the first one says you can spot transgender patient by the way that they dress or they act. Right. And so not necessarily. There are many people, patients who we have who don't actually define themselves as transgender. They define themselves by their gender identity strictly. And so they might try to go into the medical record, change their birth sex, things like that, because to them, the concept of them and the old sex assigned at birth, that concept is dead, right? So there isn't, in my experience, a good way to tell one way or another. Number 2 here says, my patient used this term to describe themselves, therefore they must know what they're talking about. And again, this is not necessarily the case. Sometimes patients are new to these terms and they might be just as confused as we are in talking about them. So the genderbread person could be a helpful tool in thinking this through. Also, terms might be important to monitor too. If someone uses a term towards themselves or towards others in a way that's pejorative, whether it's kind of knowingly pejorative or not, this could be good to assess and kind of see what the function of that term is. All right, the next one, it says my transgender patient must be gay. And we've talked about this, that these concepts aren't necessarily related, right? Someone who identifies as transgender, they may or may not also identify as gay. And the last one's an interesting one. It says things are way, way better for these patients than they were 5 years ago. And you can absolutely think that in terms of medical care and competency, that things have improved. However, I wanted to acknowledge that stating this or reflecting this to a patient, someone who's experienced certain lived experiences and hardships, will not match with their experience and could be quite invalidating, right? So this is just something to keep in mind when discussing treatment and experiences with transgender and gender diverse patients. I can remember I was giving a talk at a public health association once, and some people who are very famous in the field, they kind of raised their hands and they said, kind of, why are we still talking about health disparities research? And at the very end of the talk, someone who identified as transgender, who was local there, she raised her hand and she said, excuse me, I'm still experiencing so much strife day in and day out, that this is very relevant to me. So I think everyone at the talk was really appreciative of her voice and that comment, but it goes to show that sometimes our experiences might not directly match with an individual's experience and to not make assumptions based on that. All right. So to kind of review some of the concepts that we've been through here, the first one being that the research technical terms that we use with patients are going to keep on evolving, and it's quite difficult to keep tabs on. Similar to this, there are a few things we know about gender and about sexuality in general, that they are fluid, and that they exist on a continuum. And I think that kind of our knowledge of them will only continue to progress along these lines, but how do we stay on top of that knowledge, right? So I think as the science evolves, our ways of continuing to address one another are going to closer and more reliably match with that science, right? So our cultures kind of coming with, and other cultures are coming with use of pronouns, right? They, them, theirs, thinking about how to fit in gender neutral pronouns into the culture. Concepts around the spectrum and around fluidity and one's identity, I think, will continue to become all the more prevalent. So this is just something that's going to keep on evolving. Right, we're going to go ahead and leave kind of the terminology portion of our talk and look at some of the literature now. So if any questions come up, feel free to use the chat as I'm speaking. Right, and so the next topic that I wanted to discuss with you is called minority stress and minority stress theory. All right, a few moments ago, we were talking about like this hardship, right, that this person had experienced at this conference. And so I wanted to talk a little bit about the impact of things such as stigma and discrimination that's felt by LGBT patients. So there's this concept called minority stress that explains a little bit about this and how micro and macro aggressions come to impact mental health and actually other aspects of functioning. This concept came from the 1990s, from the literature on heart health, specifically looking at in Black Americans, why are there health disparities here that we're noticing? And from there, researchers kind of looked at other groups, and they found that this is something that's very reliable in the literature, that there are disparities based on stigma, discrimination, and other experiences that are related to aggressions that minorities might experience. And so to look at this, they kind of noted within mental health, at least, some specific findings. So first of all, that the onset of different disorders might be earlier in individuals who identified as minority. Additionally, they might notice kind of more severe symptoms in the symptoms that they do have. What's interesting to note here too is that access to services that are tailored and that are affirming might be limited. So it's kind of a harder curve to get treatment and to appropriately address these concerns once they do come up. All right. So to help kind of explain these mental health disparities, we wanted to think about what factors might go into accounting for these elevated risks, just broadly. Right? And so this theorist named Alon Mayer came up with what's called minority stress theory, and basically found that there are unique aspects related to stigma of one's identity and associated with it that are going to account for variance in explaining different outcomes. So non-specific health outcomes. I like to focus on mental health outcomes in kind of my research and my thinking. So to share this model with you, there's kind of two versions of it. One kind of for LGBT people and another for transgender individuals and gender diverse individuals. And here's what the model shows. It shows that we might experience specific stressors either to ourselves or in our environment, right? We read about it on the news or something like that, that indicate that there is discrimination and victimization going on. It might be violent or non-violent. And then that we internalize that to some extent, that we have thoughts about it. We might be more anxious or on guard as a result of it. We might actually expect it in our environments. And so therefore we might conceal our identity, right? And this, they find time and time again, this is going to lead to some negative outcomes in terms of health, and specifically mental health outcomes. All right. And so I guess a good question to ask would be, how do we kind of unravel this and work against it in our midst? If we see it coming in healthcare settings, what can we do to help address it? All right. And so there are some studies that look back in the 2000s at this question, and they kind of take a population survey level approach to what policies do the best job of getting at this, just a little bit. And so I'll talk about two of the studies today, but this is kind of a growing area in the literature. The first study is one of the original ones. This was studied published in the journal Pediatrics, that comes from a guy named Mark Hatzenbuehler in 2011. He took a survey of students in the state of Oregon, looking county by county from the years 2006 to 2008. And he surveyed 32,000 students who were filling out this survey. And what he found was that in the counties where the students had kind of a low proportion of GSAs or gay straight alliances, or that had a low proportion of bullying policies that were anti-bullying and protective towards those who identify as LGB, and also those who had a low proportion of schools with anti-discrimination policies, right? So in areas that had low proportions of these policies that are affirmative and protective, the risk of attempting suicide in those students in those counties who are minorities was 20% greater than in counties that had a higher proportion of these policies in place. That's a striking and significant difference. And then in another study since then, this is one of the most recent studies today. This study was done on 15,000 different students from 27 states, and again was kind of at a broader level. So now kind of looking at the whole US and these different states. What they found was that these students, when they have policies that support them, they're less likely to experience intimate partner violence. They feel safer at their school, going to and from school. They also find that people who do not identify as LGBT minorities, that they also experience some of these benefits just by having these affirmative policies in place. And they found that anti-bullying laws at the state level are associated with fewer suicide attempts. So having only 22% reporting attempted suicide compared to 28 during the study period. And then the severity of attempts and serious attempts requiring medical intervention was reduced as well by 4%. Right? So these are just kind of two pieces of data that look at state policies that are affirming and supportive. But with this data, the American Nursing Association has come up with several position statements on kind of the role of nurses in the field more broadly and how to implement affirming policies within healthcare. So if we kind of say, okay, we can draw up some conclusion here that having support, feeling like I won't be discriminated against in a certain setting, that matters. The ANA has taken a stance on this. Right? So first of all, they acknowledge that for a long time, health disparities have existed, and that stigma, discrimination, and denials of care, inequity and insurance have all been part of that equation. All right. Additionally, that they're committed to eliminating these health disparities where they exist, and discrimination on the basis of sexual orientation, gender identity, gender expression within healthcare settings. Right? And I wanted to point out something, and that is that when kind of these position statements have come up, and when delegates have voted kind of in favor of LGBT health historically in key moments, at those key moments, they kind of relate back to changes in the DSM and other big position changes in terms of policy. So these key moments kind of in time historically for having support from the ANA, they definitely matter, both in terms of noting changes and updates that are affirming in terms of pathology within the DSM, but then also more broadly in terms of US policy as well. Right? So given that we work in healthcare and now know about these kind of disparities that are present, how do the ANA's recommendations maybe align with best care practices or practices that we'd see reflected at VA? And then what could I do maybe within this field of nursing to make a difference based on that? All right. So we've just covered this larger question. And as we approach some of the care practices, I wanted to review some guidance from the ANA in terms of patient care. And what I'll do is I'll go through several different recommendations step by step, and then highlight all of these and how they relate back to VA care. So these come from two different position statements issued in 2015 and then again in 2018. Okay. The first one talks about setting aside bias and assumptions, which is so hard to do. But they recommend doing this by considering factors that relate back to culture, value system, examining your own religious, spiritual beliefs, lifestyle, social support, both sexual orientation, gender expression, language, and then also family and population-centered care being the ultimate goal and driver. NA advocates for the rights to work, live, study, or serve in armed services without discrimination or negative activities such as bullying, violence, incivility, harassment, or bias. To be informed and educated about the provision of culturally competent care, and to condemn discrimination based on sexual orientation, gender identity, and gender expression in accessing or providing healthcare. They also state some specific recommendations around use of demographics, patient demographics, and the electronic health record. So they talk about best practices of collecting what's called SOGI, or sexual orientation and gender identity patient data that are appropriate to the clinical interaction, and culturally sensitive care being provided based on those appropriate pronouns used. We'll talk a little bit more about this and what this looks like in VA care. Sexual orientation and gender identity patient information should be considered private patient information shared on a need-to-know basis. So it might be that some of the people we interact with, they kind of want to use their pronouns, they're sharing this, they've disclosed this information. Other people, it might be the opposite, right? We might have a special relationship with them and they want to keep that confidential away from other patients or people they might know. And they can safely store that within us. So this is what that's referring to. It might be, though, that among our teams and kind of behind closed doors, that we do still address them congruent with their gender identity or their name and pronouns that they use. Additionally, the ANA advocates for research and interventions that are aimed at improving the wellness, health needs of LGBTQ populations, including collecting data and doing more studies on SOGI and gender expression research studies. So they also advocate for talks like today's talk that's going to fill gaps in knowledge by incorporating the issue of LGBTQ populations as a regular part of nursing curriculum. And then finally, advocating for public policy that's going to be aimed at improving access for culturally sensitive and tailored care, high quality care and treatment of members of LGBTQ populations, and education that includes population health on systemic inequality, barriers, patient-specific care and interventions. And then also that accreditors and state boards of nursing require curricula on LGBTQ populations, including standardized gender-neutral terminology and documentation. And I think that this is aspirational for my field in psychology, but is a really wonderful statement to see reflected here. I know within VA, we're trying to update our electronic health record, and it would be great to kind of have people's names, which they have control over the demographics in the patient chart, but their names, pronouns, like the organs that they have in their body, for all of that to be an accurate reflection of them based on their gender identity. And then if they identify as transgender or gender diverse, to kind of where they're at in terms of affirmative care. But that is still kind of aspirational for now. All right, so we'll kind of tuck away these recommendations. And we're going to look now at kind of within VA. So I'll put on my VA hat and my lanyard here and talk about some recommendations. And these recommendations come with the knowledge that VA is ostensibly the largest provider of LGBT healthcare in the world. So studies show that there are many veterans who kind of come to VA, and VAs may be more likely to attract veterans with transgender and gender diverse identities and backgrounds than those who didn't serve in the military. All right. VA Boston and Boston's position is kind of unique in this too, because we were the first VA to have a diversity committee, I believe back in 2002. And so we were also the first to develop guidelines for treatment of transgender veterans, in fact, that have carried through and evolved over the years. Some key recommendations. So asking about or affirming all identities does not necessarily mean that you are preferring some over others. It just means that you acknowledge historical factors that might lead LGBT folks to not seek medical treatment, just as other marginalized communities might have been turned away from treatment or mistreated in the past. This just means an open environment of caring that can be demonstrated in several different ways. So one, it means that we don't shy away from those topics mentioned before, but also maybe that we're mindful and aware of our body language if we do enter into an unknown territory with someone. So to have a welcoming stance in body language. There's also different things that we can do visually that can lead to best clinical outcomes. So visual cues is something that we see represented in the literature that we know has a positive effect. So this kind of visual cues in the environment can include several things. So it can include having like a poster or a pin or a lanyard. Could involve having like magazines or literature that speak to all veterans. There's the motto kind of within VA that we serve all who serve, which is a great motto that speaks to, and we have the rainbow lanyards there that speaks to LGBT veterans, right? Typically when someone completes a training in LGBT health, so what we call a safe zone training or LGBT health 101, we'll then give them a lanyard to designate that they are competent and they've completed that training so that they can be a point person if a veteran has a question. And you might see similar lanyards or pins if you walk through any sort of medical center or the Longwood area. You might see them around lunchtime, just people floating around wearing these sorts of things or with a little sticker maybe on their work badge. All right, other things to keep in mind. So there are various videos and continuing education credits that you can do on this subject that are really fun and are wonderful ways to receive continued education from your discipline. You always have your colleagues to go through and to bounce these sorts of questions off of in terms of what helps in making conversations about identity, how to appropriately address patients if the terms are always changing, and to do so without assumptions, right? We're going to talk about what messages we send too if we skirt certain topics or maybe ignore them in our patient care. All right. I think one of the most powerful experiences I've had at my work is sitting down with someone who worked at the front desk and having them kind of on their own say, hey, I'd like more training in this area without any prompting, and just kind of seeing what that was about from the front desk staff person. So it's a very powerful statement to say, hey, there's an opportunity here for me to get additional education and beef up my knowledge, and to, without prompting, kind of go and get that information from an appropriate resource. All right. Some more specific recommendations in terms of your care would be to consider how to address a patient when you don't know them. So for instance, if you go out to a waiting room and you're calling someone back, some different options would be using honorific if it's a veteran, and then the last name, or stating the patient by their first or their last name if that is known as their preferred name in the patient chart. All right. Documenting someone's identity too can be helpful. If they have disclosed this and this is officially part of their medical record, you could choose to indicate this by stating at the top of each note their sex assigned at birth or their birth sex, followed by their gender identity. That could be how they define it in their eyes, so using the term that they use. And it could also be defined too using their name and then the pronouns that they use to refer to themselves by. So related to these concepts are going to be how we kind of talk about this in the nomenclature we use, at least within mental health. So if I work at VA and I have a patient who identifies as transgender and I want to get them some aspect of healthcare under the VA benefits package, I will give them a gender dysphoria diagnosis. So to talk a little bit about what this means, is this is a term that's used to indicate kind of general distress around their gender identity, not aligning with their sex that's assigned at birth. Some people believe that this term kind of over-pathologizes, right? It indicates a state of dysphoria, or maybe that distress isn't quite as elevated to indicate as the term suggests. So there's kind of a movement for this to be recategorized as distress, which we might see here in the future. But we want patients to receive appropriate and timely medical care. So this is the term that we will use, right? The prevalence in terms of gender identity disorder diagnoses in veterans is higher in VA than in the general population. And there's a physician who kind of writes about why this might be. It might be because someone's trying to prove to themselves, their family, their community, I am the sex I was assigned at birth. And so they enter the military and come to find out with time and with experience that kind of life feels more rewarding living in their gender identity. And so we have seen a kind of increase over the past 10 years too, and in terms of people disclosing. And that can be related as well to policies after don't ask, don't tell in the military. All right. In terms of actually strictly defining gender dysphoria, I wanted to go over what that looks like. So this can be defined as an incongruence between one's expressed or experienced gender and assigned sex at birth that lasts for at least 6 months in time. And then as indicated by 2 or more of the following. So one would be an incongruence between that and primary or secondary sexual characteristics. 2, it could be a strong desire to be rid of one's primary or secondary sexual characteristics. 3, it could be a strong desire for the primary or secondary sexual characteristics of the other gender. 4, it could be a strong desire to be the other gender or some alternative gender different from the one assigned at birth. And then 5, it could be a strong desire to be treated as the other gender by other people within their culture. And 6, a strong conviction that one has the feelings, reactions associated with the other gender or some alternative gender different from one's gender assigned at birth, right? And then that these things indicate a clinically significant distress or impairment in social, occupational, or other important areas of functioning, right? And so it might be in the future that we remove this last part, part B. It might be that there isn't a need to kind of say, okay, this rises to a certain level of impairment, but in fact, we're able to apply these great medical interventions, just noting that they meet kind of criteria based on some of the other criteria, rather than pathologizing with this term. That's something to kind of keep aware of moving forward. So next, I wanted to talk a little bit about best practices as they come from the standards of care from WPATH. All right. The Worldwide Professional Association of Transgender Healthcare has standards whose purpose it is to provide unifying guidance on empirically based and supported methods for treatment of transgender and gender diverse individuals. Right? And there are many different treatments that can be applied. So one of the most common ones that we see might be the use of gender-affirming hormones. All right, so this could be masculinizing hormones if someone's sex assigned at birth is female, and then they're transitioning to male. Or it could be feminizing hormones if their sex assigned at birth is male and they're transitioning to female. Other aspects that are advocated for in terms of the standards of care are going to include therapy, right? So especially during COVID, having group or individual support online through telehealth has really increased. Having in-person support in your community, there is no replacement for that. And so WPATH advocates for community organizations that are going to provide support and advocacy. Having vocal coaching from speech and language pathologists can be a key help. At the VA, speech and language pathologists offer this service and provide really great use of like apps that patients can do kind of on their own time to work on things like how we say words differently based on our gender and our culture, how we communicate with our hands and our body language, and also like the frequency and pitch of words that we speak. So all kinds of things that are really beyond me, but they do a really wonderful job with that aspect. Other things that might need to be accomplished would be pre- and post-operative procedures. So for instance, hair removal before a procedure would be necessary. Additionally, if a patient isn't able to have a procedure, they might get prosthetics to kind of basically try out a new gender expression and identity before having a permanent procedure that might remove or change a certain organ. So examples of this would be breast binding or padding, a tucking device, something like that. Additionally, having healthcare that affirms a person's gender identity, name, and pronouns is going to be key. Also, having identity documents from the government can be a big win. So local license, passport, having healthcare documents that also are accurate and reflect their identity. All right. And so at VA, we're able to offer tailored treatment with full knowledge that not all treatment might have stressors related to a person's gender identity and experiences at the heart of that treatment, or at the heart of their concern in seeking treatment. So some treatment will necessarily be more tailored to a person as compared to others, but certainly an affirmative approach that considers these stressors or traumatic experiences can be taken into account. So for instance, right now at the VA, we offer a DBT group for veterans with transgender and gender diverse identities. Groups and treatments can be adapted to acknowledge different forms of bias that exist within our culture and consider the context that might affect different concerns that someone has. So in terms of where this group is offered and kind of bridging that gap in care. Within VA, in terms of specific terminology that we might use and treatments that we might offer, I've included a list here. All right, so some of the things that we do is we have kind of promotion of what's called Sigi. So again, this is another acronym within VA that speaks to gender identity. And we use Sigi because it means self-identified gender identity. So again, thinking about like the name and the pronouns that a patient uses to identify themselves. As I stated before, cross-hormone therapy, what's called gender-affirming hormones, will be what veterans most often request and receive as a part of their care in transgender health. Pre-surgical evaluations and post-surgical care we also offer. And additionally, writing letters for patients who are seeking a surgery. So typically a surgeon who might be operating at BMC or a local medical center will say, okay, I want, let's say 3 letters, one from your endocrinologist, one from a mental health or a behavioral medicine provider, and one from some other physician. And so the veteran or the patient will have to go around and kind of collect these letters that show, yes, they know what's expected as a part of the surgery that they're going to have in terms of altering their body and their organs. They know what aspects are reversible versus irreversible as a part of different procedures that they're going to have. And so we are definitely able to provide a veteran who requests this with a letter. We also are able to offer name changes and kind of new fields around preferred name in our medical records system, right? And I always like to remind folks, if you're unsure of someone's preferred name, always best to ask. Additionally, we offer some really neat tools that I'll share with you a little bit later. So some national tools and trainings through what's called VHA Train. So if you're a non-VA provider, you can get some free CEs specific to transgender medicine that are now live using what's called VHA Train. You can go online and register. There's a link included at the very end and receive, I think, as many as like 6 CEs on this topic. All right. Within VA, though, we do have e-consults and then local consult points if you have a question about patient care. All right. So one of the neat things about being a student at the VA is that there's always the opportunity to get involved in kind of quality care improvement projects. So when I came to VA Boston and started my work here as a fellow, I worked on developing these fact sheets with different providers. All right. So I wanted to share with you a little bit about this project and talk about the fact sheets because they're kind of geared more for nursing staff rather than to me. So these fact sheets kind of have 2 purposes. So one is aimed at speaking to providers and has more technical knowledge, and I'll share some of that with you. And then the other one is geared more to patients, right? I mentioned a little bit earlier that veterans at VA, they kind of own the rights to everything in their demographics in the patient record. So if someone has a change that they need to make to a certain part of their demographics, their religion, where they live, what have you, they have the right to alter that. So historically, before we had gender identity kind of included as a concept in our healthcare, veterans who identified as transgender and gender diverse, they would go into the medical record, they would change their birth sex, right? So their sex assigned at birth, that's there. And the computer kind of uses that, the electronic health record uses that to auto-determine and to calculate various tests and screenings that need to be done. It will auto-calculate different lab values and levels, and some other different results if someone has like receiving a cancer treatment, for instance. So this information about one's metabolism based on their assumed sex assigned at birth is actually quite important. So what we did was we kind of noted this as a patient safety issue and said, okay, there's a group of veterans, we don't know how many, let's say 1,000 to 5,000, who have changed their birth sex in the medical record. And we want to kind of address that and let them know to consider changing it back and reverting it for the sex assigned at birth, or to at minimum let their providers know that the auto calculations that come up could result in a patient safety issue. All right. So some of the content and how we communicated this to providers looks like this. So we talked a little bit about how care can be different based on birth sex. If we think about those health screens, drug dosing, and different testing that the electronic health record is going to auto-calculate. You can see that reflected here in the bottom left. And what we did was we said there's not kind of a one-size-fits-all answer for this. It's going to depend on the patient you see. So providers should always take an individualized approach to patient care and to veteran health care. They have different factors that might uniquely influence their health care based on their existing anatomy, if they've started hormones, or things that might relate to things like metabolism, medical history, and also if they have additional goals in terms of gender transition. Right? So this is what we wanted providers to be aware of in the medical record. And then we tried to provide some outside resources too, some readings, some information about pharmacy benefits, or who else they could consult within VA. Right? But that's kind of one neat project that I did as a part of patient safety and project improvement at VA. Right. So to kind of tie things together then, before we move into the question and answer portion, and I know we've covered a lot of ground here, I wanted to talk briefly about what it would be like to be kind of in your shoes and be an undergrad, kind of considering different career opportunities. So one thing I will say that's nice about VA is that you get the opportunity to be involved in a dynamic team. There's the opportunity to educate others, learn and grow kind of in a community environment, and collaborate with others who might be on the front line. Right? It's awesome when I meet with providers who are working in primary care and they're coming up with new ways of using like a whiteboard to individually call up patients in a certain space and to use the proper gender identity, name, and pronouns. You also have the opportunity to develop trust and respect with the patients in long-term relationships, help establish new programming and residency training and so forth, and to implement novel patient-centered care and conduct research at VA. So I just wanted to put a plug in for coming to VA and considering a career within VA. All right. And kind of wrapping this up too, there are some resources I wanted to leave you with. So I'm going to walk through those now. The very first one is the most notable. It's called WPATH. And it basically outlines the standard of care for transgender and gender diverse adults and youth. All right, their standards of care can be found here. This year, they were to come out with a new edition of the standards of care, but I believe due to COVID that has been pushed back. Kind of adjacent to their standards of care is a standard of care from what's called the Endocrine Society. So they have additional guidelines that might be useful, and that comes from 2017 and can be found here. There's also some really neat videos and kind of online learning that can be done through the American Medical Association. And so I pasted 2 links that I thought were kind of most fun here. Additionally, some information that I used for today's presentation around ethics and advocacy comes from the ANA. Fenway Health also has a wonderful list of resources and CEs available. That's a local resource that's just down the road and has many kind of outpatient locations locally. Also, if you're interested in learning more about some of the concepts today, like the genderbread person, or like a list of terms, or if you wanted to run and learn more about how to run LGBT Health 101 or a safe zone training on your own, some of that information is here. It kind of all comes from the same person who developed it. VHA Train is listed here at the very bottom. There continue to be upcoming resources on transgender and gender diverse patient care, and they're kind of articulated in different modules. So for instance, if you want to learn specifically about feminizing hormones, there's like a very short 15-minute module on that. And so you can plug into very specific topics or broader topics if you prefer, and get C credit for free through what's called VHA Train and signing up there. All right. So with this, I will conclude our talk and move in to the question and answer portion.
Claire, thank you. I'm sure I'm speaking for everybody. That was wonderful. Very informative. Really excellent. We love to have some questions. It doesn't appear to be anything in the chat box right now.
Okay. And so here we have a question from Claire. What is your advice on how to approach LGBTQ veteran patients going for an endoscopy procedure? All right, so this is a really great question. And I might actually refer this question to Fenway Health, just because there is a nurse there, I think an NP there, who is really excellent at thinking about how do we make care sensitive based on people's gender identity. So there's kind of a whole host of trainings that come from Fenway Health that actually look, I think it's procedure by procedure, at a person's gender identity, kind of what terms they might use about their body and different body parts, and then about like the procedure itself that they're about to have. So I would recommend maybe seeing if Fenway Health has literature specific to, based on that veteran's or that patient's identity, and then the endoscopy procedure that might be more tailored and specific. And if I think of that person's name before the end of our meeting today, I'll share it with you, but there's an expert on this there.
Here's another question, Claire. Did you want me to read this, or?
What is your advice on how to approach? I don't know if I can see the question. So yeah,
Sure.
you can
Yep.
read it.
You mentioned that knowing birth sex can help with care. If the person has been taking hormones, though, does this reduce or erase the difference medical need to know about birth sex?
Great question. So does it reduce? I think birth sex is still, or sex assigned at birth is still just as important if someone is taking hormones, right? So based on WPATH standards, there's some nice kind of charts and graphs available partway through WPATH standards of care. So based on that, you might see certain changes in body parts if there's so many months or years into taking hormones. So the answer is, again, it really depends on maybe how far along they are. And then from that, we kind of want to see, okay, are there certain things that they're thinking about changing to their primary, secondary sexual characteristics? But again, I think it would still be just as important to know their sex assigned at birth. A good example of this that came up in my patient care would be a patient who I saw who, without their knowledge, their doctor actually changed their birth sex in the medical chart from male to female. And the reason that the doctor did this was because the veteran is intersex and had breast development. After the doctor changed the patient's birth sex in the chart, the patient then developed breast cancer. So it was actually a big saving that the patient had these automatic kind of screenings pop up. And I don't believe that the patient had started hormones at that time. And again, being intersex doesn't mean that someone's necessarily transgender or they identify in terms of being gender diverse or not. But for this patient, having their birth sex kind of listed in a way that represented their physical anatomy and represented the appropriate health screenings was really crucial to her survival. Who would I forward patients to for more information regarding the LGBT community? Their questions or concern at the Brockton VA campus. So specifically, that would be me. I can be reached at extension 61109 or my email. So first name dot last name at va.gov. And this is a question that comes up often because the Brockton campus is very large, in fact. So even to my own team there in the general mental health clinic, I need to advertise and say who I am and what I do. It's a great question.
Just going to let everyone know, I am going to go ahead and put in the link to the Survey Monkey, but please send us any more questions that you have.
Okay, this is a really good question. When you notice others not utilizing correct terms, what is your advice? So I think it depends on a few things. I think it depends on like what setting you're in, who it is you're noticing not using correct terms. And also I think it depends on if you're a student or not, right? Because there's actually a really nice opportunity to educate, even if you're not a student, but an early career person, to educate kind of up the chain in terms of this piece of information. Again, Fenway Health has a whole guide around this question and a whole guide around like a page dedicated to how to point this out to another healthcare provider. So some different ideas that come to mind would be kind of stating something non-defensively, that in my experience, or based on what I know, so-and-so goes by XYZ. Trying to kind of point that out gently to the person. There might be other times where it's like really pertinent to their mental health. So if they're in like a crisis, for instance, they're coming into urgent care or an acute setting, and then someone misgenders them, that could actually be a huge issue that then exacerbates the distress that they're currently experiencing. So it might depend then on kind of where that person is at. But if we kind of overhear it in a waiting space, or it seems like it's not as crucial to the here and now, we might have the opportunity to pull the provider aside later to talk about as a team, like if we continue to like misgender someone, or if we notice we're not using gender neutral pronouns with a patient, to talk about as a group why that might be important to address and to correct going forward. If you notice yourself doing it in the moment, which it definitely does come up, I always like to just apologize and correct. So to briefly say, oops, I caught myself using the wrong pronoun here, the wrong name, and then repeat what the correct pronoun or name was and correct yourself. And I think that that's the most common thing that I see too other providers using on the fly if they get it incorrect. Really good question though.
I had a question, Dr. Burgess, if you don't mind.
Go for
Do
it.
you find that patients are seeking providers who are already comfortable with caring for individuals who identify differently? Or do you find that providers are trying to catch pace with where their patients are? Because you referenced that 5 hours of preparation is on the positive end of the spectrum. So I'm just trying to match up where people are with where they feel comfortable caring for patients.
Boy, that's a really good point. Sometimes you might see people who kind of over-identify with being like an ally in patient care, and it doesn't always line up with provider knowledge. So I don't think that there's a hard and fast rule, right? I'm thinking about, there's a really competent provider that we have right now, a physician at my work who had all this training during residency and still will note times when she doesn't feel competent and comfortable in terms of working with folks with diverse genders. So it can come up. We might be more aware of our faults there too, with more knowledge that we get. In terms of what patients seek out though, I would say it's a mixed bag. We do see that sometimes, especially for mental health concerns, patients will say, okay, I want someone who kind of specializes in this, right? I'm gay and me and my partner are looking to have kids. So can we find someone who kind of knows a little bit about this? Or especially if someone's living at home and they have gender diverse identity, they might say, it's really hard for me to not disclose through my gender expression who I am coming back from the Navy. Can you help kind of with that? And do you have a provider who's had some experience with that before? So sometimes we will get really specific requests, but generally speaking, I think patients are quite open to working with the provider, and all providers are intended to be allies. There's not one kind of point person, inpatient or outpatient, in terms of LGBT veteran health, but all providers are kind of expected to have kind of the same working knowledge going into meeting with patients.
Thank you.
Great question.
Well, I know that Dr. Berry included the Survey Monkey link in the chat box for you folks to access if you haven't done so already. So please do access the chat box. Again, please feel free if you have any lingering questions that you'd like to pose. We still have time, but I didn't want to forget to remind folks to please complete the evaluation form no later than 9 o'clock tonight. And please, when you're completing the form, be certain to include your preferred email address on the actual form, because that will be the address that's used to forward you your certificate in the coming days. I also wanted to take a moment to thank, of course, Dr. Burgess for being with us this evening. Thank you for a wonderful presentation. Thank you for your time and patience. You, of course, are participants. You make our event possible by attending, and we thank you very much for your time and attention, and particularly for your patience in the beginning. I also would like to acknowledge and thank the VA Boston Healthcare System for their partnership and support for NERVANA itself, that is the Northeast VA Nursing Alliance, the NERVANA Planning Committee, of course, and the Faculty Development Committee and support staff here at Regis College. Again, I truly thank all of you, especially for your time and commitment amid an inexplicable year. And I, again, would like to thank Dr. Burgess too, because as she mentioned earlier, we were supposed to host this last year. So it's wonderful that she was still willing to provide her time and expertise again this year.
Always able to. We have a question from Edie, it looks like.
Oh, lovely.
I heard once that the term transgender refers to a spectrum, including non-binary or agendered, non-gendered people. Is this true? Or are those other terms part of a different gender category? Thank you. This is kind of an interesting question, because I think maybe in the future, it might be a different answer. But for now, I at least conceptually do think about transgender and then like the last part of the acronym, the GD, the gender diverse, kind of under one umbrella. But this question is really good because the latter part of it asks, including non-binary. So people who don't think about gender culturally in terms of that dichotomy, but who identify maybe as gender queer, gender non-binary, agendered, so without a sense of gender under the same umbrella. So maybe the answer is no. Maybe they would not self-identify as being in the same umbrella as transgender. And so we have a point here, the term transgender and gender expansive. We no longer use the derogatory term of non-binary, as that has an exclusionary tone. So again, thinking about language always changing. And so many patients I see will use the term gender non-binary to describe themselves. And so just saying there might be other terms that are more inclusive that they could use or might replace that term going forward. So the term being transgender and gender expansive is suggested here. Another way of thinking about this too, because the point is that non-binary has an exclusionary tone, is to think about when you write intake documents. So if we ask for someone's gender identity in an intake document, do we list dichotomous binary genders and then say like other, or do we invite them kind of in a way to include different identities and write in like a blank, like another term or something like that? So how people think about like the words on the page when we ask about this can be really important. So I used to work at Fenway Health, and when you come in and sign in for an appointment at Fenway, you can pick up a sticker or a tag that says your pronouns, and it allows you to write in your name and your pronouns. So you can write in whatever kind of you want, and it invites all people to do this. So while you're there, all individuals for a visit. Right, and so a great comment and follow-up point about that as well. And I've gotten similar feedback to what Amy C is saying too. So Amy C is saying like non-binary friends use the term non-binary. And so I have other providers kind of ask me, oh, does this patient actually use this term? That sounds outdated. And so if it's used in a way that's not pejorative and the patient uses it appropriately, then I will use that term as well with the patient. So this is a really kind of great point that's brought up here. Going back to an earlier point that someone had brought up, I believe Joanne had brought up this point about kind of how to address when someone's not using the right terminology or addressing patients correctly. And advice on that. The document that I was referring to by Fenway Health, it's called Learning to Address Implicit Bias Towards LGBTQ Patients, case scenarios. So this was developed by the Fenway Institute in 2018. And there's a full page there about different ways that you might talk about this with, like, if you're being trained by someone, with your mentor, or with someone who's a superior to you at a medical setting. So again, it's called Learning to Address Implicit Bias Towards LGBTQ Patients.
Any final questions or comments? We still have a bit of time. If not, then again, I thank everybody who made this evening possible, including you, our participants, for being with us tonight. Again, please do not forget to submit the evaluation form if you're hoping to seek contact hours or course credit. And please do so if you are by 9 o'clock tonight. And if there are no further comments or questions, I wish you all the very best. Please stay safe. And again, thank you. I can't say it enough, but I truly mean it each time I say it.
Thank you,
you all
Dr.
for having me.
Burgess. That was wonderful. Thank you.
My pleasure.